Recorded. Awesome. And yeah, thank you everyone for signing up and for joining today. We are with Home Base, and today we're presenting on partnership opportunities at the intersection of healthcare and homelessness. Specifically today, we're focusing on hospital discharge and connecting patients to homeless systems of care. So we're going to do some brief introduction of everyone who's presenting today, and then we'll get right into it. Like I said, my name is Katricia Stewart. I'm a policy analyst with Home Base, and I'm here with my colleague, Alicia.
Hi, Alicia Lemer, she, her, and I am a senior policy analyst with Home Base.
And then we also have two guest presenters today who you'll hear from a little bit later, but I wanted to give them the chance to introduce themselves. Jen, would you like to go ahead?
Hi, I'm Jen Koppel. I'm with the Lancaster County Homelessness Coalition, Link of My Home in Lancaster County, Pennsylvania.
Thanks, Jen. And Alberto?
Hi, everyone. My name is Alberto Rodriguez. I'm a Senior Director of Transformation Operations at Haven for Hope in Burke County in San Antonio, Texas.
Thanks, Alberto. And then, oh, I see Erica has joined as well. Erica, I don't know if you're able to introduce yourself yet, but.
Hello, everyone. Erica Xiao, she, her, or they, them. I'm a research associate at Home Base. Welcome.
Amazing. Thank you, everyone, for introducing yourselves. Let's go ahead and dive in. Oh, so yeah, first, if you could drop your name, organization, and something you're grateful for in the chat. And then I'm also going to put a link to a Jamboard in the chat for a couple activities to start us off, if you're able to go there. And then, so the first activity on the Jamboard is, there we go. Just brainstorming a little bit or getting a feel for the room of what existing practices you might currently have implemented for a hospital discharge. So you can like copy and paste that sticky note on there, or you can give thumbs up to sticky notes that other people put on there for what practices they have. So I can just add an example. Let's see, of discharge planning. We'll just take a few minutes to get some ideas on the board of what people are already doing around hospital discharge. Is everyone able to work within this Jamboard? No, uh-oh. It's locked. Oh, I see. Erica, are you able to unlock the Jamboard? Sorry about that, y'all.
On that, sorry about that. Try this link. Does that work?
And Teresa, in terms of joining the Jamboard, you should be able to join through the link in the chat, and then it'll open up in a separate tab.
Well, if you're not able to get it to work, go ahead and put what existing practices you do implement for hospital discharge in the chat, and we'll try to add them to the Jamboard so that everybody can see them. And if not, then we'll scrap the Jamboard and we'll just keep moving.
Yeah, folks should be able to click the sticky notes and add them now with this link. It's okay if not.
And if you are not able to join the Jamboard, please feel free to just share in the chat and we can capture it there. So what existing practices do you implement for hospital discharge?
Oh, sorry about that. I think we were sharing the link just to panelists. So Katricia, let's just make sure to do panelists and attendees when we're sharing the links.
Oh, my apologies.
Yeah,
Technology's not on our side today.
yeah. Thanks everyone for being patient.
And someone said, we are seeing our patients in the hospital prior to discharge to make sure we can communicate with them after discharge. So ensuring they have a working phone. That is awesome. And you test the numbers. I was gonna say that's a really great practice.
All right, we're starting to see some things come up. So one says utilizing our transitions of healthcare navigators for follow-up appointments, working with veterans experiencing homelessness, making sure they get connected to any veteran services they're eligible for. What else are people currently practicing with hospital discharge?
Also, we have just learning on here. If you are not currently doing anything, that is okay. You know, we are all here to learn and we're all in different stages, so.
Well, feel free to keep adding to this Jamboard or put your notes in the chat about what you're currently doing. We're going to go to the next page of the Jamboard. So if you click at the top, there's an arrow to click to the right to go to next frame. And we're hoping to get an idea of what everyone's hoping to learn from this webinar. So again, feel free to add some sticky notes or put things in the chat. And if you double click the sticky note that's already there, you can go in and edit the text, or you can click it and do copy paste and then go in and edit the text. So we're seeing some things around wanting help navigating county resources to link patients with, hoping to start the process soon and looking for some best practices. Definitely going to get some of both of that today. What else are you all hoping to learn from the webinar today? Best practices? Awesome. Definitely be covering a lot of that, so glad you're here. Seeing a lot of people seconding the best practices. Well, feel free to add to this Jamboard as we go along. And I think we'll go ahead and get started. So for today's agenda, we're going to talk about the connection between housing and healthcare. We're going to talk about planning that you can do to prevent discharges into homelessness, the requirements of State Bill 1152 and its components, application of equity and peer models to hospital discharge planning and protocols, all of which will include best practices. And then we're going to have 2 community presentations on hospital discharge and some time for Q&A. So without further ado, I think Alicia will have you get us started.
All right, thank you so much, Katricia, and thank you everyone for participating in the chat, participating in the Jamboard. You can continue to use both of those throughout today's presentation. I am really excited to provide some information on best practices and current models that are being used, but this is all getting us set up for our amazing community speakers who are going to tell you about the work they are doing on the ground. So I'm going to get us started by talking a little bit about the connection between housing and healthcare. So we know that homelessness, housing, and health are interrelated. We also know that housing is a social determinant of health. So in the field of homelessness, we often see housing instability and health needs have an ongoing cycle of cause and effect. So this means that physical health conditions, mental health conditions, adverse childhood experiences, and substance use disorders are all considered risk factors for homelessness. At the same time, the experience of homelessness increases the risk of poor physical and behavioral health outcomes. People experiencing homelessness often have high rates of infectious and acute illnesses, chronic diseases, mental health conditions, substance abuse disorders, and being victims of violence. In addition, the mortality rate is 3 to 4 times higher for people experiencing homelessness than for the general population. Based on that, programs that provide long-term safe and stable housing for people experiencing homelessness can really help to improve physical and behavioral health outcomes, including reducing the number of visits to emergency departments. We also know that hospitals are key places that people experiencing homelessness access in order to address their urgent health needs and to stabilize. However, when people are discharged from medical institutions to the street or otherwise into homelessness, it disrupts the continuity of care that was started by healthcare providers. This is because it creates inconsistencies with respect to access to food, rest, and the ability to practice self-care. It also creates unsanitary conditions for medical recovery, and lack of refrigeration or safe storage areas can make it difficult to comply with medication needs. We also know that it can be difficult to maintain contact and access to follow-up care with medical professionals as needed. We also know that clients may not have phones when they're on the street, so our access to email. And then finally, when a person is experiencing homelessness, it can make it very difficult or even impossible for them to prioritize their health needs over other essential needs, such as food, shelter, and safety. So due to all of these factors, as well as others, individuals discharged from medical institutions into homelessness have high rates of recidivism and readmission for further care into hospitals and other inpatient settings. So all of this really builds the case for the critical importance of hospital discharge planning for people experiencing homelessness. In fact, the US Department of Housing and Urban Development has said that good discharge planning is the linchpin of a comprehensive homelessness prevention strategy. So it's not just about responding to homelessness, but also preventing it. We've also seen research show that without permanent housing options, even the most effective discharge planning may fall short. So one study found that a lack of housing and community treatment impeded good discharge planning in mental health hospitals, and it increased the likelihood of consumers returning to the hospital within 90 days. And the US Interagency Council on Homelessness actually identified inadequate discharge planning as a significant factor contributing to people experiencing homelessness with mental illness and substance use disorders. We also know that effective hospital discharge planning is crucial for preventing and mitigating the spread of COVID-19 among people experiencing homelessness. This is because hospital staff can provide connections to respite care, quarantine and isolation sites, and safe shelter and housing as appropriate upon discharge. Hospital staff can also connect patients experiencing homelessness to education and information that they might not otherwise have around COVID-19 risks, symptoms, protective measures, and community resources, such as local testing sites. For patients recovering from COVID-19, good discharge planning means providing that ongoing care and recovery. People may experience long-term COVID and making sure that they are connected to the resources they need. And then another crucially important element is providing that access to the COVID-19 vaccine for any patient who is interested and willing to receive it. And that also includes providing that education, information, and responding to questions in an open and honest way about what the COVID-19 vaccine is, what symptoms might be after you receive it, and how often they might need to receive, when they need to receive their next shot, or questions about a booster shot. So now that we've established why hospital discharge planning is so important, particularly for people experiencing homelessness, we really want to get into the how and how we can use planning to prevent discharges into homelessness. So the National Healthcare for the Homeless Council has set out some steps and guidelines to help support effective discharge planning and prevent patients from exiting into homelessness. Some of these steps include developing explicit discharge planning policies, so making sure that those are formal and written, prohibiting institutional discharges into homelessness from hospitals, treatment facilities, and other institutions of care, making effective discharge planning into stable housing, an imperative outcome measure for hospitals, so really making it measurable, and then requiring the hospitals and other institutions of care help residents secure all available entitlements, including housing, connection to mainstream benefits, food, all of those things that you might need prior to discharge. We are going to hear some great examples later in the webinar that highlight these different strategies and steps. So please stay tuned because we're really going to dig into what this looks like in practice. However, one thing we know that's important to remember is that it takes significant time, effort, and buy-in to implement this type of policy. This slide highlights some of the key system-level steps that you may need to take in order to develop an effective hospital discharge planning process in your community. So the first step is going to be identifying all relevant organizations, such as hospitals, primary care providers, persons with lived experiences of homelessness, and housing and social service providers, who are going to be a part of developing your discharge planning policy. Next, you may want to set up a steering group or a task force that it involves all of those relevant groups, and make sure that you have established roles and responsibilities, and it helps set goals and deadlines for establishing your hospital discharge plan. Next, it's going to be really important to review your existing systems and processes, including what happens when a person experiencing homelessness is admitted and when they're discharged, and then what potential gaps are there and areas where new policies are needed. That review is also going to help you identify training and resource needs for hospital staff. That includes people in admissions, physicians, nursing, and social work, as well as those who are working specifically on discharge and discharge planning. Next, you're finally going to develop your homeless hospital discharge protocol, and we're going to have more detail on that piece in the next slide. As you do that, though, of course, you're going to want to test, monitor, evaluate, and refine that protocol. This may include developing and monitoring the success of a pilot program, evaluating staff and patient experiences with the new process, and refining the process based on feedback and outcomes. So as promised, this is digging a little deeper into what that development of an effective homeless discharge plan protocol would look like. And so you have 4 key pieces here. First is making sure that you're able to capture the patient's housing status during admission and obtain consent to share information as needed in order to help them with their discharge. You also want to make sure you're developing procedures for connecting patients to new housing or ensuring that their current housing isn't lost. We also want to focus on homelessness prevention, and that might involve communicating with landlords or housing provider agencies. Also make sure you're establishing processes for determining and developing resources and trainings as needed, and then maintaining a list of key agencies that are going to be notified about the admission of a patient experiencing homelessness, which may include your local coordinated entry system. So this slide highlights some of the housing and programmatic elements that may be included in an individual's homeless discharge plan. So these are just some ideas. These are not exhaustive, but some housing elements that may be included are recuperative care, boarding care, motel vouchers, halfway houses, bridge housing, and permanent housing, which may include permanent supportive housing and rapid rehousing. Programmatic elements may include, but aren't limited to, family reunification, connection to the local coordinated entry system, physical health care, substance use treatment, connection to federally qualified health centers, benefit assistance, and mental health treatment. So as we mentioned, really making sure that people are connected to resources to respond to and protect themselves from COVID is also a really important piece at this point in time. It's important to remember that the specific elements of an individual's plan is going to depend on their individualized needs and circumstances. So no 2 hospital discharge plans are going to look alike because it's really dependent on what the individual needs. So we wanted to take this opportunity to really focus on an example of hospital discharge planning being established and incorporated into policy, which is what has happened in California with SB 1152. This law was passed in 2018 to ensure that there is a safe hospital discharge process in place for all patients experiencing homelessness. So as you can see on this slide, SB 1152 requires all California hospitals to comply with the same discharge planning requirements. The law applies to all patients cared for in any acute care hospital and acute psychiatric hospitals, and ensures that all homeless patients receive a minimum level of assistance for their transition back into the community. The discharge could be from the emergency department, inpatient setting, or from an ambulatory surgery center within the hospital, and the process must be followed for all hospital discharges 24 hours a day, 7 days a week. And also, in order to make sure that all the hospitals are effectively and safely discharging patients experiencing homelessness, also requires that all patients are assessed for homelessness. So SB 1152 defines a homeless patient as an individual who lacks a fixed and regular nighttime residence, or has a primary nighttime residence that is supervised publicly or privately owned shelter designed to provide temporary living accommodations, or is residing in a public or private place that was not designed to provide temporary living accommodations, or to be used as a sleeping accommodation for human beings. So some examples of these might be living in a car or an RV, even if they are parked in the same spot every night, living in a domestic violence shelter or sober living center, or living in a tent on a sidewalk or in an encampment. And if you work in the homeless response system, you'll notice that this definition is really consistent with what we see often at the federal level and for our homeless response programs. So the homeless patient identification piece of this is really important. So we wanted to ask you to take a second and drop in the chat. What are some of your thoughts on how you can identify if a patient is experiencing homelessness? And what information or data may help to determine a patient's housing situation? So I'm just going to give a second to see if anyone has anything to add to the chat. We have someone said, I always ask, where did you sleep last night? Excellent, thank you. Any other ideas of how we can identify if a patient is experiencing homelessness? Great. All right, and definitely you nailed it in the chat. You said, where do you sleep last night? Other questions we have are, where have you been living during the past 2 months? Is this reliable housing that you own, rent, or stay in as part of a household? And are you able to return and stay there when you leave? I think a really important piece of that is none of these questions actually have the word homeless in them. People who, by our definitions, are experiencing homelessness might not identify as experiencing homelessness, or they might not recognize that that is the condition that they're in, but they will be willing to talk to you. And as Alicia mentioned in the chat, you can ask them kindly, and you get some clues based on appearances. Another clue that you might get is if you know what the address for local shelters are. If someone gives you that address, that's a hint that they might be experiencing homelessness. You also want to ensure that this information is captured in the client's medical record. This can be done during admissions, when you're collecting an address, but there's also an ICD-10-CM code specific to homelessness that you can use to capture this information. I'm going to move on, but if you have other ideas, not just on what to ask, but how to ask, please feel free to keep sharing those in the chat. So just digging in a little bit more around those required components for SB 1152. So it requires that all hospital discharge planning policies must include a homeless patient discharge planning component. Sorry, a lot of words there. But really what this means is that it's a written plan for coordinating services and referrals for patients experiencing homelessness with the county behavioral health agency, healthcare, and social service agencies in the region, as well as other healthcare providers and nonprofit social service providers, to assist with ensuring appropriate homeless patient discharges. So that plan needs to be updated annually and needs to include a list of local shelters, including their hours of operation, admission procedures and requirements, and population served. You want to make sure that when you are referring someone to a shelter, that is an appropriate and safe referral during their hours of operation. The hospital procedures for homeless patient discharge referrals to shelter, medical, and behavioral health care also have to be detailed in this plan, as well as training protocols for staff. And then each hospital is required to maintain a log of homeless patients discharged and the destination to where they were released. Evidence of completion of that needs to be maintained in a log or in the patient's medical records. So this is being tracked and enforced. So we've covered a couple of these already, but I really just wanted to highlight some of the required components because these aren't just for SB 1152. These are things that you can incorporate into your own discharge planning protocols, even if you're not covered by SB 1152, even if you're not in California. These are things that can really be helpful for a discharge planning process. So as mentioned before, all patients need to be assessed for homelessness. All information also needs to be provided in a culturally competent manner and in a language that the patient understands. The individual discharge plan also needs to be created in conjunction with and guided by the best interest of the patient, their physical and mental health condition, and their preferences for placement post-discharge. So it's really meant to be individualized and client-driven. The hospital and discharge staff must also identify a post-discharge destination that the patient agrees to go to and must document the name of the person who accepted the patient. So there's a lot of accountability there. A physical examination and determination of stability for discharge is required, as well as referrals for follow-up care, medical, and behavioral health care as needed. Patients need to be provided with a meal upon discharge, weather-appropriate clothing, and discharge medications or prescriptions. The hospital also needs to offer screenings for infectious diseases common to the region and vaccinations appropriate to their presenting medical condition, which should include the COVID-19 vaccine. Patients being discharged should also be offered transportation to their post-discharge destination. And finally, they should be helped to enroll in affordable health coverage. So of course, there is always challenges in implementing new policies and protocols, and that is true for hospital discharge planning as well. This slide just acknowledges some of the challenges that communities may face in developing their homeless discharge plan. And we have gathered these from communities that have been doing this for a while, as well as the communities that are working to implement SB 1152. So I'm not going to go through all of these, but some of them may include the stigma and discrimination that people face when trying to access services, knowing and identifying as being homeless. So once again, that might mean that people are not identifying as homeless when they come to you. Also means providing attention to that as part of your discharge planning and having strategies to help them cope with that. Also, we just know that time is always a challenge, and there may be lack of time to do adequate discharge planning. If that's the case, then thinking of ways to create abbreviated but still comprehensive processes that meet all of your goals, that might be needed in order to provide this service to everyone who needs it. Directed accountability can also be a challenge. That's why we really recommend having those written policies and procedures and those really clear roles and responsibilities that are outlined at the beginning of your policy development so that you know who is accountable for making sure that the plan is effective and carried out successfully. Then another one just acknowledges, financing can be very difficult. Communities may need to look into alternate sources of funding, private funding, foundation funding, in order to be able to do this for every client who is presenting, who is experiencing homelessness or at risk of homelessness. We know that clients may be readmitted, and even with the best discharge planning. So just acknowledging the readmission does happen and that you are planning to provide them with the safest and a stable discharge plan, but that doesn't mean that readmissions won't happen. And then eviction prevention. We talked about this before, but discharge planning is so crucial to that. We want to make sure we're intervening before it's too late if someone is in that situation where they are housed, but they are housing unstable. So keeping that in mind as well. So I am going to hand it over to my colleague, Erica, And did you want to lead us through this challenge on, or this activity on challenges of discharge planning?
Sure, thank you. Thanks, Alicia. Some really good info in the first part. So I'm gonna drop the Jamboard link again. So, and if you already have it open, you can just go on to slide 3. We wanted to just ask you all, what challenges have you experienced in discharge planning? And I saw someone say in the chat that they have troubles with the providing clothing, so I just added that as a sticky. But go ahead and add on, take a couple minutes to add on the left side what challenges you've personally experienced or your agency has experienced. Resources are inadequate. Totally hear that. And feel free, if you're having trouble with the Jamboard, to just drop your answer in the chat and we can get that on there for folks to see as well. Veteran specific issues. I see a +1 for clothing. Okay. Anything else on folks' minds as a challenge? Difficulty navigating resources and linkages, totally. Cool. And I'm seeing in the chat, UC Davis keeps a storage of donated clothing and shoes. That's awesome. I'm gonna go ahead and add that as a potential solution. Yeah, and when you've kind of thought through some of the challenges, move on to the right side of the Jamboard and feel free to add a couple stickies for what potential solutions you see for the challenges that other folks have said, or anything that comes to mind for anything we've talked about, or anything in general as well.
And I just wanted, one of the stickies says, pretty sure our hospital does not do any of this. And I think that this is, really something that is up and coming. Like, there's a lot of work around hospital discharge planning for patients experiencing homelessness. But one thing is just figuring out why the hospital isn't doing this right now. So if that line of communication isn't open yet, I think just trying to get them to the table in any way you can be really helpful as a first start.
Awesome. Cool. Some folks putting good solutions in the chat, working with partners, Catholic Charities, UC Davis. Sometimes clients may use the ER for meal and transportation. Gotcha. Community agencies create partnerships to discuss each other's challenges and discuss solutions. Totally. I think partnerships are key to this process. Just do one more minute for anyone to add any more sticky notes. And awesome. Nutritional needs that have, for patients that have specific diseases, totally. Seeing day centers as a potential solution. That's great. Feel free to keep adding stickies to this while I talk or throughout the presentation, and we can share out that link and come back to it as well. But let's talk about racial equity. Cool. So we're going to share some considerations around racial equity and peer models for hospital discharge specifically, and I will cover the racial equity section. Next slide. Cool. So just a little bit of a primer. I wanted to talk a little bit about racism as we experience it in the social sector, as well as in homelessness specifically, because I know a lot of folks on this call are coming from a healthcare perspective. So this chart kind of is something that we use to visualize the different layers of racism that our patients are experiencing, and everyone is experiencing at society at large, that kind of compound and intertwine with each other as well. So structural racism, basically the history and compounded reality of racial bias across institutions in society. So a system in which public policies, institutional practices, cultural representations, and other norms work in various reinforcing ways to perpetuate racial inequity. And then we see that manifested on institutional, interpersonal, and internalized levels. Institutional being policies, practices, and procedures that produce inequitable outcomes based on race within institutions. So an institution could be a school, an organization, a hospital, etc. And interpersonal racism within that is kind of the public expression of prejudices and bigotry, so between individuals within these institutions. And then internalized racism is like private beliefs about race within individuals. So on the healthcare and homelessness level, we're trying to account for all of these layers of racism when solving for racial equity in our systems, but specifically targeting the institutional level, in this case, in hospitals and hospital systems. So just a little bit more, thank you, next slide, please, on the racial inequalities in homelessness. So I'm not sure how many people have seen charts like this before, but basically most minority groups make up a much larger share of the homeless population than they do of the general population. So if you can see here, for the Black population, the chunk of the graph that accounts for homeless is significantly higher proportionally compared to the percentage of the US population. And that's the same for most minority groups, besides Asian and white, where folks experiencing homelessness are proportionally less than of the general population. And then next slide. The rate at which most minority groups experience homelessness is also greater. So this is a chart measuring the number of people experiencing homelessness on a given night per 10,000 people in the population. So as we can see, Native Hawaiians and Pacific Islanders have the highest rate, American Indians and Alaska Natives following that, and then followed by African Americans, 2 or more races, and then Hispanic or Latinx individuals. Next slide, please. Cool. So in the context of the medical system, this is something that we're kind of facing right now in our vaccine distribution work as well, but there are a variety of reasons that communities of color have distrust in the medical system, including systemic violence done against Black, Indigenous, and people of color on a policy and institutional level. So there's been histories of unnecessary, unsafe, and non-consensual medical experimentation specifically for the Black population. So for health and homelessness providers, we need to be empathetic of this and have the tools to understand client distrust among BIPOC clients and patients. So for more information about this, we're going to link a WorkSafe webinar on Black-centered equity and community engagement, and we recommend watching at least the minutes that are marked on this slide. So it's about 15 minutes to just get some additional context about medical distrust. So Alicia or Katricia, could you please drop that in the chat? Appreciate it. Cool. And then all that is to say, racial equity should be at the center of all the work that we're doing, because of all of these historical inequities that we are trying to account for and take responsibility for. So here are some things that we can consider from a racial equity perspective in hospital discharge. So taking specific health needs into consideration with discharge planning is really important. Acknowledging that racialized trauma may be a part of the story for your clients and patients when developing comprehensive care plans. We're going to talk a little bit more about a peer specialist program to build trust between hospital staff and clients as well, that Katricia will cover. And then also just in terms of the staff itself, it's really important to implement diversity, equity, inclusion, and belonging practices in the hospital staffing to hire staff that are representative of patients' backgrounds, again, to form culturally competent responses, and then also training staff in cultural competency to specifically center that in any response in terms of hospital discharge, and particularly for patients experiencing homelessness. This is who are disproportionately BIPOC. This is extremely vital in making sure that their care is as good as it can be, which is the goal for all of us at the end of the day. Cool. Thank you, everyone. I'm going to hand it over to Patricia now to talk about peer models, which also deeply intertwined with equity.
Thanks, Erica and Alicia. So far we've covered the connection between housing and healthcare, preventing hospital discharges to homelessness, what the State Bill 1152 is, and the requirements of hospital discharge planning in California, and the challenges of discharge planning, as well as how racial equity might apply to hospital discharge planning and protocols. So now I'm going to talk a little bit about how peer models might be able to support hospital discharge and hospital discharge planning. So first I want to talk about what peer models are and the components of peer support. So peer models are frameworks for providing services and support that center around peer support. So peers are those who share similar experiences or backgrounds. A peer supporter is a person who has knowledge from their own experiences with a condition or of the circumstances of those that they help, or has received training to be empathic and understanding in helping. So in this case, a peer would be somebody else who has experienced homelessness. A peer specialist is a person with lived experience of a specific healthcare need, or for example, homelessness and recovery from substance use, who has been trained and certified to help their peers gain hope and achieve specific life and recovery goals. So there's kind of different levels to peer models, but a peer specialist is a certification. The four components of peer support are up in the upper right-hand corner there, and they include assistance in daily management. So peer supporters use their own experiences with diet, physical activity, and medicine adherence in helping people figure out how to manage their chronic diseases and other conditions in their daily lives. The social and emotional support component, that's through empathic listening and encouragement. Peer supporters can help individuals cope with social or emotional barriers to staying motivated to reach their health goals. In regards to linkages to clinical care and community resources, peer supporters can help bridge the gap between the individuals and health professionals and encourage them to seek out clinical advice or treatments when appropriate. And they can also help in identifying key resources in the community, such as where to buy healthy foods or pleasant and convenient locations for exercise. And finally, ongoing support extended over time refers to peer supporters successfully keeping individuals engaged by providing proactive, flexible, and continual long-term follow-up. Next slide, thank you. So why peer models for hospital discharge? Providers face two major challenges while engaging with people experiencing homelessness in healthcare. Those are one, finding and engaging these individuals in a way that builds trust, respect, and mutual understanding. And two, keeping those experiencing homelessness or formerly homeless engaged in healthcare. So unlike many health workers, people who provide peer support, known as peer supporters, share similar knowledge and experiences of those they're providing support to, which places them in a really unique position for providing practical, social, and emotional support to others. Peer support's non-hierarchical, it's reciprocal, it's flexible, it complements and enhances other healthcare services, and it supports trust building and engagement with marginalized populations. Lived experience of homelessness is essential to engaging people experiencing homelessness in healthcare and other homelessness services, and helps with building trust quickly. So basically, peer models can help healthcare workers engage with people experiencing homelessness through the trust building and emotional support that it provides. Just a quick note on, on trust. This trust component is so crucial for this population and for healthcare engagement. And someone with lived experiences of homelessness can more readily build rapport and trust with others experiencing homelessness. This can then lead to the peer supporter helping the individual maintain better healthcare regimens needed to support them after discharge, with trusting doctors and other healthcare workers' advice, and with trusting essential medical offerings like vaccines. So once this trust is built, practical social and emotional support can continue with the peer supporter, creating like an upward spiral that helps to maintain their health regimens and engage future healthcare as needed. Peer support specialists typically work in collaboration with providers and case managers, and can also coach the participant on what to ask during a medical visit and be available to debrief on how it went. Basically, peer supporters can really enhance the entire process and really help to build those bridges with certain populations like those experiencing homelessness. And in this case, they can also help with or do discharge planning if they are hired to do the discharge planning. They can support the discharge process in other ways, or they can help the hospital staff make connections to the local continuum of care and services. But ideally, dedicated hospital discharge staff could be peer specialists who have experienced homelessness. Next slide. How peer support models support safe and equitable hospital discharge planning. We did talk about some of the limitations or barriers to successful hospital discharge, and peer models can really help to mitigate or counteract a lot of those barriers. So if you had dedicated staff who were peer specialists, they could help solve the issues of time or accountability. Peer specialists who are dedicated discharge staff could also support the consensus process, training, and tailoring of the process to the local community. These peer specialists could also help to counteract the discrimination and stigma that individuals experiencing homelessness face, building trust with patients, which can also help to promote their cooperation, follow through, and coordination. And this all would help to counteract relapses, and all of the above could incorporate eviction prevention as well to prevent any future episodes of homelessness. So building off of that, some of the contributions and benefits of peer support are listed on the slide here. And basically, like, if you're able to incorporate a peer support model into hospital discharge, as well as other aspects of the healthcare system, such as like street medicine, which we'll talk about in our next webinar, you're really going to get more buy-in and cooperation and trust building and better health outcomes for people experiencing homelessness. Next slide. I wanted to also quickly touch on equity in peer models. It can be really easy to think that people who are peer specialists or peer support workers should volunteer their time, or that they should just know what to do already because they've had a similar life experience, but that's not necessarily the case. So incorporating an equity lens into this means providing training for peer specialists or peer support workers on equity and whatever other aspects of the job that they might need. Ensuring that peer specialists are representative of the populations they are supporting. So in this case, you want to make sure that the peer specialists are people who have experienced homelessness or who share similar health conditions or backgrounds to the people at the hospital that you serve. Like if you work at the VA, you might want a veteran who experienced homelessness. Equity also means ensuring that peer specialists and peer support workers are fairly compensated for their expertise, time, and labor. So this should not be volunteer work necessarily. It also means ensuring that folks who would like to be peer specialists but do not have potentially required training, like education or a certification that would allow them to work in a hospital, that there are opportunities provided to them to acquire that training so that they are eligible. Especially of issues with inequity and homelessness, barring certain groups from participating in peer models due to educational requirements further perpetuates inequities. So instead, it's important to consider what trainings might be required for your healthcare setting and how you could offer those to people who are interested in peer specialist roles. All right, I'm going to hand it over to Alicia to talk about some additional best practices.
All right, and I am going to talk about these very quickly because these are some best practices that our community presenters are already going to speak to. And we are really excited to hand off the baton to them because they have so much great experience to share with you. But one thing we really did want to make sure we highlight is that medical care and recuperative, medical respite and recuperative care is a really important piece of the system and the puzzle. That provides acute and post-acute care for people experiencing homelessness who are too ill or too frail to recover from a physical illness or injury, but they're not ill enough to stay in the hospital. So they're kind of stuck here where they're still recovering in a pretty intensive way, but they can't stay in the hospital and they're not going to recover well on the street. So medical respite provides short-term residential care that allows individuals experiencing homelessness the opportunity to rest in a safe environment while also accessing medical care and other supportive services. It can be offered in a variety of settings, including freestanding facilities, homeless shelters, nursing homes, and transitional housing. Here you can see some of the program standards. There are a lot of standards around medical respite programs. They're really about just making sure that people are safe, they are able to carry out their activities of daily living in a supported way and with wraparound services, and that they are receiving high quality care, both during their time in medical respite as well as after, and that those transitions to wherever they're going next to additional care are being really safely supported. So this is all happening along a continuum of just making sure that people are really safe and supported on their journey to not just health recovery, but also stabilization in other parts of their life. So if someone is going from the hospital to a medical respite program, you also want to make sure there's very good discharge planning there to make sure that they are leaving to a safe and stable housing situation. Care coordination, we've talked about throughout this process, and our presenters are going to speak to, but really just making sure you're working with all of those people who are invested in the health and well-being of your patients experiencing homelessness, and making sure you're collaborating around creating your discharge planning policies, creating culturally competent trainings, making sure that you're connecting to those COVID-19 resources, and that you're understanding the unique needs of individuals experiencing homelessness in your community. There's a lot more on this slide just about ideas of how you can collaborate, but we're going to get even more from our presenters. I think Katricia really hit this already, but having dedicated staff, ideally that represent patients' background, is such an important piece to this. It can really help ensure that your hospital discharge planning is effective and that you're building that trust and relationship with your patients. Dedicated staff responsibilities may include coordinating care, completing intensive housing searches, working with landlords directly, tracking discharges and outcomes. That's a really important piece of this. Creating and implementing the safe hospital discharge protocol, and providing training and education. So with that, I am very excited to introduce and hand it over to our community presenters. We have Jennifer Koppel, who is the director of Lenco My Home. We have Alberto Rodriguez, who is the senior director of transformational operations for Haven for Hope. And I am going to hand it over to Jen first.
Good afternoon. So I'm going to start with a little bit of a background about Lenco My Home. Right now, and you can read on the slide that Alicia put up, basically who we are, but at the same time, it doesn't really also explain that we're over 200 partners strong coalition. We're in our 11th year, and we are currently housed within Penn Medicine Lancaster General Health, and that's part of the broader Penn Medicine system on the East Coast. And what's really fascinating about that is for the first 4.5 years of our existence, we were embedded within county government, behavioral health, developmental services department. And there was a reason for that. And at the time that the coalition was created, the board of commissioners for our local government felt that it was important for the government to have, to step in and put some resourcing towards the coalition. So they had designated our department as the home, so to speak, of the coalition. And I was the deputy director there. So I picked this up as part of my job duties. About 4 years in, we really learned that homelessness was way more complicated than just behavioral health and developmental services. It was much more, lots of physical complications, trauma, childhood experiences, all of the things that we know today, we didn't know 7 years ago. And we were also seeing an emerging connection between healthcare and housing. And we approached the Board of Commissioners and said, would it be possible for us to be moved off the county government structure into another organization, a nonprofit specifically, where we could fundraise, because we couldn't fundraise successfully at the county, being part of the government. And we also weren't able to be part of foundation, grant applications, anything like that. So we just felt that we could be more nimble and responsive in the community. Plus, then there was this emerging connection. So we did put out a call for community organizations to share interest with the county government on housing us. And at the end of the day, Penn Medicine was chosen. And Penn Medicine is in Lancaster General Health is the largest health system in the county that we're in, and it's also the largest employer. So it made sense in a way for us to go somewhere where we had a synergistic relationship, that we were able to continue to be autonomous and work independently, but also build that connection. So we've been at Penn Medicine 6 years. It was 6 years in June. And we've taken a lot of time just really building relationships. That's part of what our focus has been in the coalition. Almost 3 years ago, we started a strategic planning effort. We rebranded, became Lanka My Home, and we really started to focus on how we build collective impact in our community. I have a team of 3 others, including excluding me, so I have a total team of 4 that's designated to this work. We serve as the Continuum of Care Lead office for our collaborative application. We also serve as a coordination site for any of the funding that comes into our community that's tagged towards homelessness. And then we also write applications, maintain compliance, launch programs, set vision and strategy, a lot of that administrative function. Alicia, can you go to the next slide for me, please? So I wanted to put together something that was more of a visual about how the coalition actually works. So it is a partnership between county government and healthcare. You can see on the left part of the slide what the county provides to us. They have a contract with LGH, Lancaster General Health, for us. There's money that comes into our office for services. It doesn't necessarily pay for the staffing of the office, but it does pay for services that we manage on behalf of the county. And then we also do the HUD compliance, and there's some grants that go with that. And then we have some other additional grants that we support. And then on the far right, you'll see what LGH provides to us. Again, LGH is Lancaster General Health. Again, they don't necessarily pay our staff salary and benefits because we're funded through grants that come into our office, but they are literally the ones that are paying us. They are also paying for our health care and our benefits. Our health care and our pension benefits. It's all of the administration support in the background, legal, accounting, compliance, anything that you would, HR, anything like that. And then we have our office spaces included and our administrative assistant support, and then IT and infrastructure marketing stuff. And then in the middle, you can see where the coalition exists, which is the 200 plus partners that I referenced. And then that's what my office is sort of managing, is that vision and strategy. We have a board that does grant approvals. We facilitate collaboration and all of that. So to that end, we stood up all of that structure in the first maybe year to 2 years. And I directly report into the emergency department by design. The reason for that is because of the high rate of recidivism of some of our folks into the emergency department for those services. So it was determined that that might be a good place for us to at least start that intersection. So we do have a very strong relationship with the emergency department. The emergency department has access to our homeless management information system software, which is called Empower Lancaster. It's powered by Caseworthy. So the emergency department social workers can see if somebody comes in and says that they're homeless, that they can see who they are, where they might be getting services. So they're not duplicating a referral, but also so that they can connect to other services to kind of fill out, that rounded holistic care. So that's our first place that we connected. And in the subsequent years, we've really determined a number of different spaces where homeless or community benefit organizations can intersect with healthcare. And we've become a centralized place. When I was talking to Alicia about this the other day, I call it a translation function. And what we oriented ourselves around when we did our strategic plan 3 years ago was really the language of social determinants of health. Because that's a language that the community benefit organizations are largely providing the services in that social determinant of health space, but not necessarily using the language that the healthcare system is. So we sit in the middle space between those two functions, and then we offer that translation. And we offer our connections, we leverage relationships, we build relationships on behalf of the hospital and healthcare system, things like that. So since then, I started making a list. So if I look down, I'm looking at my list to make sure that I touch on all of the projects that we have in play with the hospital right now. So remember, we started with just that simple connection of getting to know what does the emergency department do, how does it work, what are the pain points of discharging from the emergency department, and then how can we help connect on the other side and build that shared language and common agenda. Those are principles of collective impact. So moving forward, the emergency department has an ability to directly refer to our low barrier shelter, so that they can discharge directly from the emergency department to the shelter. And we have rooms that are set aside, or beds rather, that are set aside for LGH to do that. In addition, about 3 years ago, we're coming into our 4th year, we started a program that we call crisis housing. We call it crisis housing because it made more sense to our community, but for the individuals who might be working with continuum of care dollars, it's the transitional housing rapid rehousing combination program that was launched as a bonus project a number of years ago in the continuum of care grant. We were awarded one of those, and we call it crisis housing. And there's 3 sites to that. 2 of them are for rural populations, but the one that applies here is for a program that Lancaster General has. It's called Care Connections. Care Connections is a mobile medical team that works with individuals who are really medically complicated, very vulnerable, and at the top of the pyramid of users. So they're likely dual eligible Medicare, Medicaid. They have lots of medical complications, lots of social determinant of health issues. And we created the program so that Care Connections as a team can discharge directly from inpatient. So remember, we created a pathway for the emergency department to discharge directly to shelter, but we also created a space for one of the inpatient care teams, this Care Connections team, to discharge directly to this crisis housing program. And then what happens on site there is, because the person is coming into that THRRH, Transitional Housing Rapid Rehousing Program, they automatically qualify for a subsidy if they need one in order to find a rental unit and maintain that for a period of time. But they then have that longer term stay that they can also access on site. Plus, then the Care Connections team that has the medical care in that mobile fashion comes on site and provides that, so that they know where the person is and they can help, keep that person more stable medically, while the person's also then getting support to look for housing. So as we moved through the last year, coming into COVID was quite a challenge. But I would tell you that even though we had to stand up, I'm sorry, I see a question. What category of HUD funding for the crisis housing program? That's a transitional housing, rapid rehousing out of the continuum of care grant. I don't believe that that's a current repeated, I think it was a bonus project. We haven't seen it since the bonus project that we applied for, but we're hoping that that is a bonus project again when the grant opens soon. When we came into COVID, we had to stand up a number of programs very quickly. One of them was a quarantine facility or quarantine site. We did use a hotel for that, and we set up very direct protocols with Lancaster General Health on testing and referral to the quarantine site, so that if an individual who was living outside, unsheltered, or living at one of our emergency shelters, then and came in for COVID testing, they were directly transported from the testing site out to the quarantine facility. And at the quarantine site, they were connected with food from our emergency mass shelter and medical case management. So there was a very robust set of protocols that put into place for that, also for testing. When we had, an exposure or something like that, we worked very closely with Lancaster General to set up some very strong testing protocols for COVID. With COVID came a lot of challenges in our community around our visibly homeless, or visible population of people being outside. And I backtracked from saying homeless because we know, because of our street outreach teams interaction, that not everyone in this category of people is actually literally homeless. There is a very strong presence of open substance use in our city area. So what we worked on with the city was to expand our outreach team, but that also included the emergency department and some discharge planning from there as well. And then we connected with our Lancaster Behavioral Health Hospital we have a freestanding behavioral health hospital in our community, and we incorporated them into this outreach team so that they were also better supported, so that they were not discharging directly to the street, because we were having some issues with that from their side. So we brought them into a street outreach team. And then if we continue to think about how do we support folks from coming into the emergency department. So we have a discharge protocol to help when people are coming out, but we also connect them once they are out in the community with a community paramedicine program that can help connect to a medical home and insurance and benefits and whatnot. So, and we've tried to create as much of a robust, not robust, but a rounded set of protocols so that we have good connections within the hospital, so that we are not just discharging people without connecting them to services. Our office fields a lot of calls from the inpatient social workers and the care navigators to make sure that, you know, folks know where people are going and can they get discharged to units. Our housing market is exceptionally tight, as most places, so it's extremely difficult to get somebody placed into an actual apartment from, you know, inpatient. So we try to set up some of these other programs, almost like a staging area or triage area, so that they can go into the next place. And then we did open a day center in response to COVID. And then again, also the emergency department and inpatient has direct access to discharge into those. And then the kind of our capstone project at the minute is our next slide. Alicia, can you go to the next slide, please? So we launched, we're launching a mobile hygiene unit, and we were supposed to get it in the spring, and I was lamenting the delay of it to Alicia because of supply chain issues. We're still waiting for it. But we heard very clearly from the individuals that are living outside that they want showers, obviously, and we do not have, in Lancaster County, did not have a way to consistently offer that across the county. So we purchased this truck, a picture of it in the corner, and it's going to be providing showers and sinks so folks can shave, brush their teeth, take a shower. We'll have mobile medical care with the community paramedics that I referenced earlier. We'll be able to offer telehealth, behavioral health services, connect folks to social services and housing support. We also are going to have our comprehensive care team present, which is HIV prevention and harm reduction. And then we'll be launching a street medicine program in partnership with Lancaster General in September, I think. And that will also be providing some more robust medical care in the shower truck, and then also working with individuals who are living outside in encampments and whatnot. But I wanted to show this slide because all of the organizations that are on this slide is what it takes to lift up a project like this. And the thing that we've learned in the 11 years that I've been with the Homeless Coalition is that you have to have these kinds of relationships. And I want to point out two specific ones. You see PHFA, that's the Pennsylvania Housing Finance Agency. And you'll also see the Lancaster County Community Foundation. Those are the funders that actually helped us buy the truck. And then you'll see the Lancaster County Housing and Redevelopment Authority. The Redevelopment Authority is what's helping us pay for the operations of the truck. So we literally took 3 funding streams together to buy and then operate the truck. So it's that kind of complex work that communities are really struggling, and it's not easy. I would tell you that it took us 7 years literally to get this truck up. But I would say that the focus that we've taken on partnerships and relationships and building collaborative environment, we also use words that safe to fail. That was important for us when we rebranded, that we as a community agreed that it was okay to pilot things and test things and iterate on things. And if it didn't work exactly as we had planned, it was okay, we could change it. And that culture of safe to fail has really gained a lot of traction in our community, and it's really pulled the coalition together. And I would tell you that in the last year with the pandemic, and even if you account for the honeymoon period that most communities feel in a disaster, the coalition has really gelled together and is really functioning as one thing. And that takes all of those partners to respond to successfully support people. So it's been a long journey, but I would tell you that it's totally worth it on the other side. So I think that's my 15 minutes. I will pass off to my co-panelist.
And that was great. And Alberto, I'm going to get your slides up, but feel free to jump right in.
Thank you, Alicia. So thank you. I want to shout out to Jen for saying that they love pilots. So that's one of the things my team makes fun of me here at Haven is I have so many intake pilots. They're like, okay, what pilot are we on now? And it's like pilot like 100, just because it has made makes work a lot easier when you're trying to propose processes and protocols that are different when you started as a pilot and then make changes as you go through the process. So a little bit about me. My name is Alberto Rodriguez. I'm the Senior Director of Transformation Operations at Haven for Hope in Bexar County. So we are a transformational campus for individuals experiencing homelessness in Bexar County and San Antonio. So pre-COVID, we had roughly about 1,700 individuals sleeping at our shelter each day. Because of COVID and the need for social distancing, our occupancy was limited to right around 1,300. So we're still one of the largest homeless provider here in Bexar County. So we try to do as much as we can to keep everyone safe. So on the first slide, just a little bit about Haven and our history. So we became fully operational in June of 2010. So we opened our doors on April 2010. Because we had so many beds to fill, we kind of wanted to do a pilot of enrolling individuals slowly to make sure that we were providing the best care for everyone that was coming in. So we offer transformational services to men, women, and families with children experiencing homelessness in Bexar County. So we have two portions to our campus. We have our low barrier program, which is called the Courtyard. The Courtyard's for anyone over the age of 18 that can care for themselves and is not a danger of threat to themselves or others. So registered sex offenders, individuals that are actively using substances or actively under the influence, we actually encourage that they do come in because it's a safe space for them to stay. So we do search everyone that's coming in. You can't bring in the substances with you or the paraphernalia with you, but we do have a space for you to sleep, and it's safe. It's all indoors. So everyone's able to kind of come in. We have staff 24/7. We have over 600 cameras at our facility. It's a 22-acre facility. So we have the safety component to ensure that it's safe for you to be under the influence here. We actually prefer that than you being vulnerable out on the streets or somewhere else where you could be taken advantage of. Since opening, we've graduated just about 6,000 individuals from our transformational campus into permanent housing. Again, our transformational campus is our residential program, so that's a bit more high barrier just because we do have minor children in this residential program. So we have to ensure individuals are able to meet some eligibility requirements regarding substance use and things like that. And then one of our biggest things is our success rate, and our length of stay is around 141 days for single individuals and 113 days for families. That's from the time they come into our program and go into permanent housing. Permanent housing, as we all know, looks different for everyone. Individuals are able to get reunited with family members or friends. We provide all of that assistance, or go into their own apartment, either through housing subsidies, through federally funded HUD programs, through our coordinated entry system, or housing programs that we at Haven have that we fund with state monies to be able to get them that rental assistance and that monthly rental deposit assistance, security deposit assistance, I'm sorry. And our percentage of individuals that maintain housing for over a year is at 89%. The way we track this is our HMIS system has about 74 partner agencies that provide services here in Bexar County for individuals experiencing homelessness. So the way we track our individuals of not gaining or recidivism is that they don't receive a service through any of those 74 partner agencies that are providing those services. Next slide, please. So for our point in time count since opening Haven for Hope back in 2010, our downtown homeless count has decreased by 77%. So again, Haven for Hope is right in the middle of downtown. So we're able to bring in those individuals, engage with them through outreach, and offer them those shelter services and getting them into permanent housing. So to talk a little bit more about today's subject, which was one of our biggest needs. So in early 2016, what we were seeing is we were seeing a growing concern of individuals coming in from hospital systems that were either being dumped or unsafely discharged onto our property. Most of this time, these were individuals that were being dropped off at our gate or benches on our campus. Like, as I mentioned, it's a 22-acre campus, so it's a pretty big area. And individuals were being dropped off at all times of the day, even times when intake was closed. Agencies, cabs, EMS, they were just dropping them off in the corner bench or the bus stop and expecting that the individuals would make their way to Haven. And if they were able to make their way to our intake department was closed most of the time. So we began tracking some of that data. So what we found is through June and August of 2016, we had 80 patients that were unsafely discharged. What I mean by those 80 clients is those 80 individuals that were completely unsafe to be here. They weren't able to meet their ADLs. They were able to take care of themselves. They did not know why they were at Haven. That was not explained to them at the hospital. So having those conversations with the hospital system to let them know, you know, this individual's not here, calling EMS back. EMS would come back, assess the individual, and determine that the individual needed to be hospitalized and Haven was not an appropriate place. So on top of those 80 unsafe discharges, we would have unplanned discharges just as frequently. Again, our definition of an unsafe discharge are those individuals that were coming in, no clothing, only the hospital gown, no undergarments, individuals coming in with PICC lines and IV lines that weren't even removed at the hospitals as well. So it was those really unsafe discharges where someone could be vulnerable and or in danger of something happening to their life. So with that, as I mentioned, we had to have a lot of those difficult conversations. I was at intake at the time, so I was having these difficult conversations with the hospitals about this individual was just dropped off. They have documentation or your wristband that they were at your hospital. We just want to know and understand why this individual's here. They weren't aware that they were being sent to Haven or they didn't know what Haven for Hope was. So having those difficult conversations as late as 10 p.m., midnight sometimes, with that hospital staff and those discharging staff, and then kind of letting them know what we had to do to ensure that patient safety, which in most cases was calling the Adult Protective Services, making that report to ensure that that individual going back to the hospital would be appropriately discharged and appropriately taken care of. One of the biggest things that I found out with those difficult conversations was just misconceptions about what Haven for Hope could offer. So a lot of the directors and discharging staff believed Haven for Hope to be a medical facility because we did have CentraMed, and I'll go into details about our CentraMed clinic. Because we had CentraMed as one of our partners on campus and on site, they believed we could provide that medical care and could be a form of respite care for these individuals. So again, it was just having those conversations kind of led to finding out, okay, there's a bigger issue here. It's not necessarily that they're just dumping on Haven or dropping off at Haven because they don't want to treat a homeless individual. It was more so trying to, they thought we could provide more services than what we were capable of providing. So the next step in what we did was just being able to have those collaborations and those partnerships with all these organizations. So I mentioned CentraMed earlier. So in July of 2016, I met with the leadership at the CentraMed Sarah Davidson Clinic, and that clinic has been the designated healthcare for the homeless agency in our community to provide services for individuals experiencing homelessness since 1981. And they receive federal funding to be kind of that medical home for our shared clients. So the clinic first opened its doors back in April 1st of 2009. That was a year before we even opened our doors here at Haven for Hope for our shelter. And individuals experiencing homelessness that have been seen through the CentraMed Clinic are also eligible for that the transitional care for up to 2 years once they graduate the shelter programming. CentraMed's able to provide the primary care visits, lab work, medications, and coordination of care, all for free for our individuals experiencing homelessness. So I knew I had to go to them, being that they were on site as well, literally right down my office, to be able to talk to them about how we were able to build, if we could collaboratively build a policy and a protocol for hospitals that were discharging to Haven to be able to make sure that this was a safe process. So I sent the form over to Alicia, and we can send that out to individuals. My contact information will be at the end as well. So we collaboratively worked on this form to a checklist of sorts that the hospitals would fill out ideally, and they would fill out, send that over to myself. I would provide that to CentraMed, and we would go from there. So in September of 2016, we started our first pilot with the University Health Systems, which was our largest referring hospital that was referring to Haven for Hope. We met with them directly, CentraMed and Haven for Hope. We met with their director and in charge of discharge planning. And we had the conversations about, this is what we're trying to do. This is a collaborative effort. We want to help you ensure that you're discharging patients to appropriate care, but we also want to make sure that the patients that are coming to Haven for Hope are able to safely be here. And if not, how can we work on getting them into appropriate placement? So we had those conversations. They were on board. They saw, obviously, they wanted to do what was right for the clients, as did we. So we started that pilot. We were meeting with them weekly to determine if the form was working for them, if they had any suggestions or any edits. And within the first quarter of 2017, we had signed in, on all the other partner agencies and all the other hospital systems as well onto this pilot to determine that they would fill out this form to then be able to make referrals directly to shelter system. So the next slide, part of our process was, again, creating that safe referral checklist. Our intake department would review for the form to be completed and the documentation needed on that form. We would then send to CentraMed. CentraMed would review the file and clear the patient medically to be able to care for themselves. At that point, we would then call back the hospital, schedule an intake appointment time, and prioritize enrollment for that individual so that that individual was being discharged during intake hours, and then send that individual back to CentraMed upon discharge for a post-discharge appointment with their PCP to get the medication, get them the care that they needed, and as well as scheduling follow-up care. So what we saw in fiscal year of 2017 of tracking this data was that we were able to find a reduction of 60% of rehospitalizations for individuals within that 30-day mark. What we were finding a lot for our homeless individuals as well was that they were using the hospital system as a way of respite from the storms, from the weather, a meal. So if we were able to connect them with that follow-up care, or they were also using him as a primary care physician instead of using a doctor. So we found that if we connected them early on, that they would not go back to the hospital unless it was truly necessary. And I want to be mindful of your time. So again, part of our partners was CentraMed, the largest health systems here in San Antonio University Metropolitan Baptist. And then in 2019, we also partnered with our mental health hospitals to have a similar process for individuals that were being discharged from crisis, like EDs and things like that. And it has worked wonderfully as well. And then just my last piece, and I'll share my contact information. Keys to our success with hospital discharging has been having those quarterly meetings with all of the hospital systems and our partners to ensure that they understand the process, make sure that we're meeting with staff that have turned over. They all have my cell phone, so they call me 24/7. And we also offer regular tours to all their staff so they truly understand what Haven for Hope is, so that they know who to, when to refer appropriate clients. And then that's my contact information. If anyone has any questions, you can either call me directly or send me an email. I'm happy to send and chat about information, forms, and processes that we developed.
Awesome. Thank you so much.
Yeah, I just wanted to say, awesome job, and we will be sending PowerPoint so that if you miss anything, that you can catch it. Erica?
Yeah, no, that's great. Thank you so much again, Jen and Alberto. We will be sending out the slides and all the information from this webinar. We'll also drop the link to register for the next webinar. We're going to be covering street medicine and equitable vaccine distribution. So there's the link there. And you'll also see that on the slide. And then as Katricia put in the chat, it'd be awesome before you log off to just put in the chat one thing you learned from this webinar that you are going to implement in your organization. Thank you so much, everyone.
Yeah, thank you all so much for attending. We hope to see some of you at the next webinar next week, same time, same link, I believe. Yeah, and please do email us if you have any questions or follow up as well.
Thank you to our fantastic our fantastic presenters. Thank you. That was a ton of information, and I think that it was really great for all of our attendees.
Thanks, everyone.
Thank you.